All right, well, welcome everyone. As you mentioned, I'm Amanda Simmons. I'm the Executive Vice President for IHP, and Hope Kraatz is with me. Hope is our Assistant Clinical Director for the network, and we're excited to talk to everyone today about how FQs can drive quality and change in a very challenging world of healthcare reform and patients. And so we'll move right in, give you a little background of our network. So we are a clinically integrated network located in Southern California. We have 9 FQHCs. On the left, you'll see our members. We are an FQ-controlled risk-bearing organization in California. We serve 2 counties, San Diego and Riverside counties. And our vision overall is to advance pop health, enhance patient and provider experience, reduce cost and hospital utilization, and improve quality and health equity for our patient groups. The network itself was developed to allow our health centers to come together in what we call co-opetition, where they collaborate and compete at the same time to better our patient experience and really become a community resource that drives change through data and through clinical best practices in our areas. Network by the numbers, we are quite a large Medi-Cal network. So Medicaid in California is called Medi-Cal, so you'll hear us refer to that a number of times, but we are 350,000 plus lives under management. We have 1,300 health center clinicians. We have 667 specialists, 95 clinical sites over those 2 counties. As I mentioned, we have 9 FQ members, and we have 5 payer partners within the space. So our reach is very large. We own predominantly the majority of the market in San Diego County and a large portion in Riverside as well. But 1.3 almost million visits for our health centers. And we really, our services as a network, since we are FQ controlled and we were FQ built, is to provide wrap services for our health centers in a network setting so that we can provide continual value add to our members. Our services within the network range from, we do policy reform and advocacy on behalf of our health centers, managed care contracting and operations, coding and clinical documentation, audits and education. We do care and case management. We have a population health management tool called Arcadia that we aggregate all of our different EMRs. We have 6 different EMRs across the network. Hope's team also focuses to quality process improvement and where do we close gaps and really address patient needs and equity. And then we have a pop health informatics team that continually looks through data, the lens of data, to help drive change through data, be it claims data or EMR data, and provide transparency to our 5 payer partners. IHP over the last 6 years has been really focused to quality improvement. And, initially we were in primary care cap arrangements and have evolved into full professional risk arrangements now. And so our network, initiated in 2016, and then we've seen considerable growth and improvements in quality that in a second we'll go over. And so our challenge to our team is to add value to our members as well as add value to our patients. So just to make sure everyone understands, so Hope and I are probably some of the largest advocates for FQHCs because it's our mission and our heart. But community health centers, we're non-for-profit, patient-governed organizations. that really focus to the vulnerable populations and ensuring that we catch and these patients have access to care. Across the nation, according to NAC, which is the National Association of Community Health Centers, 1 in every 11 Americans are homed within a health center. 19% of those are uninsured. 61% of those are publicly insured, meaning on the Medicaid system. 90% are low income, 41% rural residents, and 64% are of a racial ethnic minority group. And so, as you can imagine, our patients that we serve are the most vulnerable patients with the most challenges. And so our health centers are committed to those patients. And in an FQ space, they cannot turn away any patient with the inability to pay. And so we have to come up with creative solutions as a network and as a group of health centers to ensure our patients have the right care in the right setting by the right provider. So as I mentioned, when we first were initiated, we were in the primary care is a form of alternate payment methodologies, but we're actually in the midst of the transition to value-based care and value-based payment reform. And so, thinking of the difference within the space is going from a population-based versus an episode-based. And so what we challenge our health centers to do is the 350,000 patients that we have attributed, we have to think of them regardless if they're in your 4 walls or not. And so it's a full approach to engagement of every provider and every payer or every community-based organization. And it's a team effort to move this patient into the space where they are achieving access and equity. So the key goal here is that it's patient-centric and it's a true population health technique that in the end, will reduce costs, but we tend to lean more to access and quality, and that cost will follow. So some of the key tenets that we focus to as a network, and these obviously are not all of them, but just some highlights. Care management, and Hope was going to spend a lot of time this afternoon in this space. Coding, we are firm believers that our providers are doing the right work for the patients when the patients are in the clinic, but are they capturing it correctly, and are we reporting that correctly to our payer partners? Network management, ensuring that we have the highest of providers within our network and that everyone's working to the top of their license and that they have the ability with real-time reporting. Patient engagement, we believe that nothing we do should be outside of immediate impact to our patients. And so patients should have a voice within our network. So we spend a lot of time with outreach and stakeholder input to make sure we hear the voice of our patients. As you can imagine, in Southern California, we have a high Latino population. And so we have to be very mindful of culture and equity issues there. Physician engagement and compensation, even though we are a clinically integrated network, which means we are a little bit different than an IPA. IPA is physician owned and led. We really pride ourselves that our physicians are at the table with every piece of movement we make as a network, because they are the ones that are doing the hard work and the heavy lift. And so we engage them in our committees and our work groups and every piece along the way. Same with staff. Our staff engagement, not just at the network, but also at the health centers, from check-in to janitorial, we really encourage them to understand and we provide education on what is value-based care and why is it important and how does their role impact it. Technology and data. I think we could probably spend an entire day on just that one topic. How do you take such a vast amount of information and make it sizable, and you have the ability to use the data to drive change? And then finally, utilization management. So or referral management, depending on which side you're on of the process. having an active role in both the UM and the referral management to ensure that the patient is receiving, as I mentioned, the right care in the right setting by the right provider. So those are just a few of the key tenets that we as a network focus to make sure that we are providing value. Some of the things, as I mentioned earlier, quality, we just focused quality so much. So we spend a lot of time within the HEDIS space, which I'm sure a number of the organizations on this call do as well. IHP this year was named the top performing network for quality across the state of California for 2 of our payers, because we're able to aggregate data and really drive change through either case management, care management, gap closures, patient navigation, and all the different tools that Hope's going to speak to. And so we just included some of our HEDIS measures for reference. We do, as a network, prioritize our HEDIS measures because the state of California, every payer has their own priority of HEDIS. We are in the process of a reform effort called the Managed Care Accountability Set that we are trying to bring together the quality so that all payers report the same and that we're held accountable to the same. But cumulatively, when you look at our expectations of both HEDIS and operation measures, we have roughly 70 plus measures that we're held accountable to. And so as a network, we prioritize those so that Hope and Dr. Lee, who is our medical director, can really drive change with focus with our CMOs and our clinical communities. And then over time, as I mentioned, so this is one of our payer groups that we pride ourselves in, that IHP just continually has, back in 2016, our quality was the baseline, and we've shown drastic improvement with a number of our measures through some of our techniques. And we continually work with our payer groups to make sure that we're challenging ourselves every year, setting the bar one step higher. Our payer community, one of the things we do as a network is, as we move into new either risk-based agreements or conversations, our payers are side by side with us. And so it's not a throw the ball over the fence accountability process. We really challenge our payers to sit at the table with us, and having 350,000 lives, you have the ability to get some attention from the payer community and really represent our FQs and make sure that they're getting the resources they need to really address these gaps. And then finally, I mentioned this earlier, we are the top performing provider clinically across the state of California for 2 of our payers. And so we challenge the teams one step further every year. And so this is just a visual of how San Diego versus Sacramento and Inland Empire and things, if anyone knows California, these areas, how we compare. And so our next year challenge will be to take it one step further and go beyond that. So that gives you guys an overall view of just the network and kind of our primary focus. And I think what everyone's more interested in is Hope's presentation on, and how do you really begin to impact and leverage risk stratification and care management in the specialty space. So Hope, it's all yours.
Thank you. Yes. Hi, everyone. I'm so glad to be here. Like Amanda said, we really are focused on data, but now how do you make data impactful and to drive change? This is an example here of how one tool that we have help practices manage population on a risk stratified care. Today, I really want to focus in greater detail how practices can identify and manage their populations, and the importance of leveraging data to help improve patient outcomes. And risk stratification is how we do that. So as we talk about risk, I want to review what risk stratified care management is. Risk stratified care management is a data-driven approach that prioritizes patient-centered care and that aims to improve quality while controlling cost. It involves categorizing patients into different risk levels based on their health status, medical history, and potential health risks. The stratification process segments patients into groups based on complexity and needs. And once patients are stratified into risk groups, healthcare providers can provide a tailored care management strategy to meet the specific needs of each patient. For instance, high-risk patients might require more intense care management and include more frequent monitoring and follow-ups, while the low-risk patients might benefit from more preventative care, health education, and might not need as intensive services. So who should be part of the care management team? Care management consists of all the team members that are in touch with patients. Like Amanda talked about, we want to leverage every healthcare provider at the top of their license. So understanding who touches that patient and how to do that is helpful when we are identifying the key players of strategizing care. One of the benefits of risk-stratified care is it allows for the delegation of work to be distributed evenly, and it empowers us all to take charge of patients. So it's no longer left on one person or the physician to drive the patient experience. We all play a role and an important part in that. So how does risk stratification improve performance in value-based care, value-based contracting, and really kind of get you the performance that Amanda highlighted? This really is a proactive approach, that allows providers to intervene early and prevent any disease progression or serious complications, even death. It promotes the most effective means to utilize resources and allows us to target our care more effectively. This approach also can help improve overall efficiency of your organizations. It allows for us to optimize our care teams, identify what our roles play, leverage our resources, and ensure that patients get the right care, right time with the right outcome. That has been our motto. That's how we drive our initiatives, ensuring that patients get the services that they need. According to industry standard, and the reason kind of why we're talking about risk stratified care is according to industry standard, we found that a mere 5% of the population is responsible for 50% of healthcare expenditure. Many of these patients have advanced illness that require ongoing needs with multiple specialists. Being able to identify how complicated and potentially at risk your patients are helps you align with the strategies that most are impactful. I'm going to go back to my slide here. If you reference here, you can see at the top of the slide that, or at the top of the pyramid, you will note that that's where our advanced illnesses are and where many of our complexities are. But we want to take a look at just right below that on what are rising and at risk. That's where we have the potential to make the most impact in improving outcomes, controlling cost, improving quality. And that's where the meat is in developing strategies for care management and risk stratified quality care. Let's see. This here, we'll go to this slide. This slide, there are many approaches to risk stratification. Some are very complex and costly, but there are simpler approaches as well. This is a model that's endorsed by NAC. NAC's stratification model is based on chronic condition counts as a method to segment patients into categories. This approach is based off the adjusted clinical groups model developed by Johns Hopkins to identify the high-cost users. And it's really an easy and effective way to stratify populations to really kind of start targeting interventions. The process of stratifying by condition helps develop cohorts of patients that may benefit for a lot of resources, and then cohorts of patients that don't necessarily need a lot. This process can be supplemented by your providers and care teams to make referrals based on patient severity, social risk, utilization patterns, etc. You will note here that we also talk about where does the risk fall within the stratification process. And in the low and rising risk, you will see that's where our most potential is. That's our prospective risk. Strategies that you can deploy within this segment of patients are care gap closures, cancer screenings, annual wellness visits. This is kind of where we have the most potential to make the impact. A lot of times too, you will see this is where we can really affect our quality or HEDIS goals. Then we can move into the high risk and highly complex. You will see high risk has 4 to 5 chronic conditions, highly complex has 6 or more. And this is where these are the types of patients that already have advanced disease or smoldering kind of disease or potential for actual risk. This is where the level of services may need to be a little more intense and where case management may need to do more one-on-one interventions to help manage the risk. There's a couple of things to think about as you're developing a stratification scale. And the 2 key things for us in our practice is, number 1, we have to have a re-stratification process. The way many of our practices do that now is we're doing that with an annual wellness visit. And when I talk about re-stratification is someone may come into our system and they may be identified as low risk. And this year I am 50 and I'm very low risk, but next year I may have developed diabetes and depression, who knows. And having that reassessment piece and ability for physicians to do an assessment, and then here's where coding really comes into, where we're coding appropriately and efficiently to assess where that patient lives within the scale. And I may be more now a rising risk. So developing strategies and interventions that address my potential risk is important. The second thing that needs to happen within this scale is we need to have judgment. Clinical judgment is really important because, as we know, we can't fit patients in a box. Everyone has their own nuances and different comorbids that affect our care and cause us to be more or less at risk. So making sure that we have those abilities to discern or be able to have clinicians be able to discern when patients are high risk or low risk. For example, we may have a patient that had coronary bypass surgery. He has diabetes, newly diagnosed asthma, and maybe depression, and he would be considered a high risk patient. But after all the intense interventions that our care management teams and physicians and care teams do to deploy on patient care, this patient was able to really get their diagnosis under control and might not really be a high risk patient anymore. Even though they have 4 to 5 chronic conditions, they may be more of that lower rising risk. So giving the ability for clinicians to be able to discern within that scale is important. Here, this slide just demonstrates what profiles of these risks or risk segments look like. Highly complex is really that 5% of the population. Those are really those high utilizers, like we reflected. They have 6 or more chronic conditions and really do probably require a lot of intense services. From our practice's perspective, from the FQ space, a lot of times these patients are already engaged with specialists. So really the focus is coordinating that information and coordinating that care and ensuring that the PCP is still driving those conditions as well as being in charge of their care. So that's an important piece with a high complex. For high risk, those are not quite as sick. They may be moderate users of the health system, but they too also have 4 to 5 chronic conditions. They look to be about the 20% of our population that we're looking at. Patients may require more specific one-on-one case management, may not be as highly intense, but the whole goal of that segment is really to manage the risk, to prevent them from becoming catastrophic, and ensuring that they get the services that they need and care is coordinated. Then we can flow down into the rising risk, and this is where we have the most potential to make the impact, and this is where our prospective risk is, where things have not occurred yet, but we have the potential to make the impact. Patients in this segment of the scale have 2 to 3 chronic conditions. They may be more lifestyle management risk factors, and a lot of times deploying scalable strategies that are dispersed between the whole entire team is the best strategy to help these rising risks. Again, like I said, they are the focus when we're in value-based contracting because they have the most impact on how we perform. Then we have low risk patients, and these are about 80% of our population, and they are really the patients that are not utilizing care very much. We don't want to like disengage them or just ignore them. We really want to keep them engaged in our health system. But we don't have to utilize the resources that we would for the highly complex to keep them engaged. Many of our health centers are looking at texting campaigns, annual wellness visits, health screenings, etc., to keep those patients involved and manage their risk. So now let's talk about steps on how you build a program. We've kind of organized this into kind of 5 sections of work, but I wanted you to note that the provider is at the top of the continuum. We believe that care is done best when it's done at the PCP level, and developing care management strategies that are led by physicians are really the best and the most successful in my experience. Starting off, we want to look at patient selection. And this is where we identify all the patients that are attributed to your health plan, regardless if they've been seen or not. This kind of changes our lens from the patients that are that just come in for a visit to looking at their entire population. Many times you get this information from health plan eligibility, but there are other forms to receive as well. This is the time that we're going to start to stratify your population to understand where all of patients should be segmented into and who we should focus on first. Another strategy at this step is really to start focusing on empanelment of your practices and just evenly distributing the patient populations to your providers. This is also an opportunity to start shifting to timed visits, how many visits, and looking at strategies of outcomes and population management tools. Once we have identified our patients and we've stratified, we can move into the enrollment step of care management. And this is the patient engagement step and probably the most important. Obviously, if our patients aren't engaged, we don't have a lot of effectiveness in deploying very many strategies. So developing methods that we can ensure that patient engagement is secure. Number one is making sure that we have right phone numbers, right contact information, etc. Health plans are really also a good help in helping us discern that information. But annual wellness visits are really also a really key time to make sure and verify that patient contact information is accurate. The other thing is really, this is where we talk about physician-led, is having our physicians start driving the conversation and introducing them into those care management programs, regardless of what they are. Each patient will have, based on their risk, will have a different level of enrollment needed to be participating in care management. For example, for our low risk patients, enrollment is not necessarily a phone call or a physician handoff. Enrollment may be a text reminding them that their annual wellness visit is due or that their breast cancer screening is due. And enrollment for maybe a high-risk patient will look different in the sense that those are complex, advanced disease type patients, and that may require more of a physician handoff, team huddles, and more collaborative care opportunities that we would see with that segment of patients. The third step that we outlined is case management. Now, within our populations, not all patients need case management, but it is an important step in the management of the risk of your populations. Within the high risk and highly risk complex cases, case management probably is one of the best interventions to the one-on-one intent services, but case management doesn't always have to be that way. Necessarily, maybe for the low risk, it's more of just a coordinated effort or a warm touch at their annual wellness visit. The fourth step in building a risk stratified care management program is coordination. Again, depending on the risk level, this intensity of intervention is different. For low risk, it's It may be just coordinating their annual wellness visit and keeping them engaged with your health system. For more of the high risk patients, that may be doing more of the referral management pieces, ensuring that the patients get to the right network, ensuring that information flows back to providers, ensuring that care is coordinated between all the specialties and that patients aren't lost in the system. The fourth step in a care management program is graduation. It's probably the most important step and a step that I see gets eliminated most often. And a graduation step is really that evaluation piece. Like we talked about, patients don't always stay in the same risk segment that we've initially identified. So developing strategies to move them into the appropriate risk category, as well as to graduate them out of their program. In my experience, case managers like to hang on to their patients for years and years and years. It's a relationship that they have with them. It's important, but making sure that the interventions and strategies and the risk that we have identified is appropriate for services. So we can't do risk stratification without, well, we can, but it's difficult to do risk stratification without community partnerships. Community partnerships offer numerous benefits to FQs and their ability to expand services and manage the underserved. Some of those key advantages are enhanced service delivery, collaboration with community partners. FQs have the ability to expand their service offerings and provide a more comprehensive range by partnering with others. Additionally, it helps increase access to specialized services, specialized care, and it allows our ability to share data. Here's one example how we have partnered with Arista MD to help control some of our ancillary or specialty services by the use of e-consults. It has benefited our patients in the sense that, number one, they have a better patient experience, they have eased access to care, ease of initiating engagement with their visits, as well as it makes impact on reduction of referrals to specialists and outside the network, and there's a better patient experience. So with that being said, that kind of concludes what our program is and how we leverage the tools and data necessary to really able to perform well in value-based contracts, as well as promote good quality care amongst our unique membership. So thank you.